Hello, I'm Dr. El Sanadi. I'm a board-certified emergency physician. I'm the EMS medical director for several agencies in Broward County. I want to talk about airway management. In every acronym, whether it's for American Heart or for PHTLS, A is airway. Airway, breathing, circulation, expose, and then mental status. With that, I want to spend some time talking about airway management and how critical it is. Why do we manage the airway? Why is airway so important for both the American Heart algorithms and for the trauma algorithms? Airway. Why? We need to open the airway to make sure that we maintain oxygenation. The O2 saturation should be higher than 94% for all patients. And this is what we strive for, oxygenating the brain, the heart, and other tissues. As you walk towards the patient, anticipate a difficult airway. Does the patient have a short neck? Does the patient have a bull neck, a thick neck? Has the patient had surgery on their neck? What is their neck mobility? Are they 87 years old and do they have kyphosis and a bent spine? You have to look at that and you have to think, will this be a difficult airway or will this be an easy airway? Are they a pediatric patient? Large tongue, large occiput, short neck. You have to actually look for all those things and anticipate a difficult airway. Once you've mastered the fundamentals, how to insert an oropharyngeal airway, a nasopharyngeal airway, how to use a bag valve mask apparatus, how to maintain a patient's O2 sat over 94%, then you can move on to getting ready for an intubation. You have to have your stylet. I prefer a stylet in the endotracheal tube. To be honest, I like a bougie also. And I prefer straight blades. And with that, I always check the bulb, I check the handle, I make sure I position myself in a comfortable position, and then the patient is positioned optimally so that I can align the blade to see the vocal cords. The most important part as far as proving that you've put the tube where it should belong is watching the tube go through the vocal cord. Once you have all your equipment and all your supplies ready, and you have your straight blade or curved blade in, and you're looking at the vocal cords and you try to pass the tube. How often should you try? My max is about 7 to 14 seconds per attempt and no more than 2 attempts by one provider. Who should attempt the intubation? The most experienced operator, especially if you anticipate a difficult airway. My usual is 2 attempts, no more than 7 to 14 seconds per attempt, with oxygenation in between the attempts, and then from one operator I would move to another operator, try one more time or 2 more times. If that fails, then I would either go on to a bridge device, or in the event that an airway cannot be maintained and the O2 sat is constantly below 94%, I would actually contemplate doing a surgical airway. How do you prove, other than visualizing tube going through the vocal cords, that the patient is intubated correctly? Well, we have several methods. Certainly the O2 sat, monitoring the vital signs, looking for hypotension and bradycardia, although those are late signs. Using the turkey baster or the suction device, watching vapors in the tube. With inhalation, the tube should be clear. When the patient exhales, there should be steam in the tube. So that's fairly accurate as far as the tube being through the vocal cords into the trachea. Also, definitely auscultation, listening to the lungs, and also the epigastric area. There shouldn't be any epigastric sounds, and there should be symmetric breath sounds bilaterally. So those are the 5 ways you can actually prove and document that the airway is placed correctly and the patient's oxygenation is good. End-tidal CO2, O2 sat, monitoring the vital signs, pulse, and also, of course, vapors in and out of the tube using the bulb suction device and visualizing the vocal cords as you're passing the tube. After you intubate the patient, what are you going to do? Are you going to continue to bag the patient, or does your transport unit have a ventilator? You have to learn how to use these devices so you can assure that the patient not only has a stable airway after anchoring the airway around the neck, but also that the patient will continue to be ventilated and maintaining the O2 sat over 94%.